Okay. Thank you. First of all, thank you very much for inviting me to this conference. It's my first time here, and I enjoy very much meeting all the people and these interesting subjects. So the next 20 minutes that are about drug interactions from a pharmacist's perspective. So only for a pharmacist, from theory, it's very simple. You can say don't take more than 2 drugs, or even better, just 1 drug, and eat every day the same meal. But for you as a patient with CML, and plus hypertension, maybe plus diabetes, plus asthma, sometimes you have an infection, sometimes you have pain, and you want to eat different things, especially if you are in foreign countries and go to such conferences, that seems to be difficult to handle like that. So there are some options to handle this problem. You can just take your drugs and wait what happens. So fortunately, most of the time nothing will happen or nothing will harm you. But sometimes the side effects or the effect of this problem is difficult, or you have side effects, or you have no drug effect. So the other opportunity thing is can look the literature, look in the internet, you can calculate the dose. You have a lot of lists, you have thousands of drugs, you have many interactions, you have many problems, and you can calculate, and maybe you will find a solution for that, even not a pharmacist, or it takes a long time. So that's not really practical as well. So I would try to give some basics to you, that with some basics and with a doctor and with a pharmacist who is there to answer your questions and who knows your situation, your drug therapy, even if you have to take more than 2 drugs, should be safe. So then let's start with some basics or with some theory about drug interactions. Basically, there are 2 problems. There are the drug-drug interaction. That means 2 or more drugs react with each other. That's the common if you have more than 1 drug. Or you have as well drug-food or drug-beverage interaction. So there are food which may interact with your drug. The clinical effect may be different. Fortunately, very often there's no clinical relevance. So once more, there will happen nothing. But sometimes the drug is less effective. And I think that's very critical in your situation with CML, because you can't really look for the response, or it takes some time to have the response. It's much easier if you have drugs, say, against hypertension. If you then have another drug to take it with you, you can look, is your blood pressure higher or lower, and then you can react very quickly and change the drug. But with CML and with the effect of the drug, it's really more critical to have less effects. The other thing is that the drug is more effective. That's quite good if you have a better effect, but on the other hand, you have more side effects. So here it's the same as Dr. Shah told in the morning. There are some side effects which are not really life-threatening, or you can see it. If you have more diarrhea, you see it very quickly, and then you can react as well, and you can reduce the dose of the drug. So that's okay, but if you have side effects which are not really dose-dependent, or which you will see later on, that may be a problem. So I want to show you the wave of the drug throughout your body and look where drug interaction may occur. That's all the pharmacokinetic interactions. So you have this LADME system. It's liberation, absorption, distribution, metabolism, and excretion. So if you take a pill, that will go to your stomach and will be there dissolved and will be absorbed in your stomach or in GI tract, and then it will be distributed throughout your whole body. It goes to the liver as well, and within the liver there will be a metabolism, or your drug is transformed into an inactive substance which may be excreted by the kidney. So the most places where interactions can take place is the absorption within the stomach and the metabolism in the liver. The excretion is for TKIs, your drugs you take, not that important. So I won't focus on excretion or distribution. I will only focus on absorption and metabolism. With the liberal and absorption, the tablet will dissolve within the stomach. That takes about 20 minutes with a normal tablet. There it will mix with food if there is food in your stomach. And then it will transit the stomach into the intestinal segments, and there will be the absorption. Most of the absorption will take place within the intestinum. So if a large amount of the drug is absorbed, the drug has a high bioavailability. You call it, if it's the same as you take a drug IV and the whole drug is absorbed, you compare those data and you have maybe a bioavailability of 100%. But that may be influenced by the food. Some drugs are absorbed by a lesser extent if you have food in your stomach, and some drugs with a higher extent. So that may be a difference. And also the transit time may be different. If the transit time is longer, there may be a higher amount of the drug which has been absorbed, or if you have diarrhea and the drug is for shorter time in your GI, you maybe have a lower absorption. And the other thing which may be interesting for TKIs as well is the pH. That is a measure for the acidity in the stomach, may influence the absorption as well. From a pharmacist side, you have the AUC, you call it the area under the curve, and that's a measure of the amount of the drug which your body is exposed to. So I did that to make it a little bit clearer. The OSA is a standard measure of drug exposure and indicates how much of the drug reaches the bloodstream and how fast it is eliminated from the body. It can also be considered a level of bioavailability and how much is being absorbed following the administration of an oral drug. So this area under the curve, or the curve, may have different shapes. You see the red curve. It has a high concentration very quickly, so the drug is absorbed very quickly, and then it's very quickly excreted by the body, so you have a high concentration and a short time, and have a certain amount of area under the curve. And the green shape, so there's a slower absorption. You have a lower concentration or maximum concentration, but it's for a longer time. And the AUC may be the same. And for the effect of a drug, the AUC is responsible or is a good measure. So sometimes you find, if you compare different drugs, how much the AUC is affected by food or by drug, and then you have a measure what you can do or whether you have to reduce or to increase the dose. Sometimes it's written with a meal or without a meal with different drugs, but here you can see a meal is not a meal. You have sometimes a fruit salad, which is a very light meal, or you have meat and dumplings and sauce and a very heavy meal. And so you can imagine within your stomach, it's really different how long this meal will be in your stomach, or what about the transit time. So that may be an influence on the drugs as well, what kind of meal you had. Here I have listed all the TKAs which are on the market at that time, and all these suggestions how to take the drugs. And the suggestions are taken from the EPAR, that's the European Public Assessment Reports. That is something about the drug, which is published by the EMA, by the European Medicine Agency, and you can look for that. It's open for everyone, so it's not restricted to doctors or to pharmacists, it's open for every person. And so the two first, the bosutinib and imatinib, you should take with a meal. There is a little bit influence, but it's not that relevant. And if you take something with a meal, if you have GI problem, it's even better if you take a drug with a meal, because then the GI problems are not that bad. So the suggestion is to take imatinib, for example, with a meal and with a large glass of water. Looking at dasatinib and panitinib, so it doesn't matter whether you take it with or without food. You see there is a little influence, but it's not clinically relevant. Therefore, it should be that you take it every time at the same time. So the influence is very low, but there is an influence, and so it's better you take it every time for breakfast, or normally you eat breakfast similar things. So you won't eat for breakfast a very high and long and heavy dinner, and take it every time for breakfast. Then you have all the time the same circumstances and nearly the same absorption, and so it's quite safe. The only drug which is a little bit critical regarding the food is the nilotinib. You should take it without food. There are some studies which had been taken, and they showed that food increased the area under the curve by more than 80%. That means if you take it with a meal, you have the double dose nearly. And then you can say, okay, I take it all the time with a meal, and I have to take only the half of the dose every time. But that's difficult because it depends sometimes on the fat, how many fat is in your meal, and so that will be different. You won't eat every time the same meal, so that may vary from 50% to 150%, and so it's not really safe because you have every time another dose which you take. So with nilotinib, the suggestion is really to take it for an empty stomach, and that means 1 hour before a meal or 2 hours after a meal. And the only thing which is written that you can take it with applesauce if you are really unable to take it, but not really with a really meal, because then the area under the curve is higher and you have higher drug levels. The influence of the pH is a critical point of the TKIs, because the solubility is influenced. There will less drugs absorbed if you have a lower pH. So drugs and acids, they bind the acids in the stomach, or H2 antagonists, they block the histamine receptors, which are for the production of acids responsible, or the proton pump inhibitors. These are drugs which are a little bit complicated with TKIs. So in general, you should use with caution or try to avoid that. The only thing which is quite sure are antacids, because they are only for a short time within the stomach, and you can take it with a time difference of 2 hours with the TKIs. We go now to the metabolism in the liver, and that seems quite complicated as well, but with TKIs you can reduce it to some important problems. The drugs are metabolized, that said that are changed into inactive substances by enzymes, and the enzymes help a reaction to happen more quickly. And it's mainly by the so-called cytochrome P450 system, and there are more than 50 isoenzymes which make it sometimes complicated. And the possible interactions are that you have a competitive metabolism with other substrates of the same enzymes, that says that there is a certain amount of enzymes, and they can only metabolize a certain amount of drugs. So if you have 2 drugs with the same enzyme, you will have reduced drug levels. And all the TKIs which are known are substrates of one isoenzyme, the CYP3A4, and there are many other drugs which are substrates as well: amlodipine, atorvastatin, erythromycin, clarithromycin. So a lot of drugs which are more or less metabolized by the same enzyme. So you have careful with those 2 drugs. And it's in this list as well, there's all these have substrates, and they're inhibitors of well, but I won't focus on this point. The next possible interaction is that you have CYP3A4 inhibitors. These are drugs which will block the enzymes in the liver. So if the enzyme is blocked, that means that you have less metabolism, less inactivation, more active drugs, higher drug levels, and therefore more side effects with those drugs. And a potent inhibitor can increase the area under the curve 5 times. So you have 5 times more drug than without this CYP inhibitor. So there are some antibiotics like clarithromycin or erythromycin, some antifungal drugs, or drugs against HIV, which are inhibitors, and there are many other drugs as well. On the other side, in the opposite, you have some drugs which induce CYP. So they increase the production of more enzymes, and if you have more enzymes in the liver, you will have more inactive drugs, you will have reduced drug levels, less drug effects, and maybe an effectless therapy. This takes some time because these enzymes have to be synthesized, so with only one dose, you won't have this effect. If you take it for a longer time, and it may be seen after 2 or 3 weeks, the whole effect. So you have some antibiotics, rifampicin, rifabutin, carbamazepine or phenytoin, which are anticonvulsant drugs which are used with epilepsy. And you have St. Clown's wort, which is a herb, which is very common in Germany to take it if you don't really feel well, but it's very crucial to take it with TKIs. So here is only a list which is taken from the EPA to show the effect on with inhibitors and with inductors. You take ketoconazole and rifampicin as model drugs just to show the effect. And here are some more herbs with potential interactions, but only St. Clown's wort is really clinically relevant. The other, if you take it in a normal amount, it's not really relevant. But it shows you that if you buy herbals, which is very common in Germany, and some people think it's not really important to tell your doctor that you take those drugs, they can have interactions with your drug. And the other thing is food or beverages, and that's grapefruit, which is a fruit which is very crucial with those drugs, and I think it's a good idea to have on this breakfast buffet no grapefruit juice with a conference with CML patients, because grapefruit is an inhibitor of the CYP3A4, and 200 milliliter of juice can increase the level of drugs threefold. So it's not really wise to take grapefruit if you take TKIs. There are responsible some ingredients, and these ingredients are as well as in Sevilla orange and in some limes and pomelos. And it's one grapefruit or 200 milliliters which can have this effect. You are quite sure if you take just orange juice from Nerval or Valencia oranges, they don't have those ingredients. Because this interaction is in the liver, the administration at different times don't avoid the interaction. Even if you take grapefruit juice for the breakfast and have your pill in the evening, there will be the effect. Another point is genetic differences. Sometimes it's called about that you have in different populations, different activity of the enzymes, but that is only affecting different CYPs and not the CYPs which are important for the tyrosine kinase inhibitors. So it's not really a subject for you up to now. Maybe if there are other drugs, you have to look for that. But in the moment, it's not, don't have a clinical relevance. So for summarizing how to avoid interactions, I think at first it's very, very important that your doctor or your pharmacist really know all drugs you take. Even if you have a complementary drugs or over-the-counter drugs, the doctor should know it and your pharmacist as well. And then you have to look whether there's really a reason to take that drug, whether you have an indication, or whether this indication has changed. Is it still necessary to take all the drugs you take? And the less drugs you take, the less interactions there are. If the drug is really necessary with an interaction, you can look for alternative drugs. It's not the same that it's a class effect every time. Sometimes you have drugs of the same class and different drugs where the isoenzyme profile is different. Your pharmacist should know that. Or is a drug reduction possible? And if you have really to take this interactive drug, then you have to watch careful for your side effects. Have you more diarrhea because of this drug? Watch the effect of the drug. And you can monitor the drug levels, but that's not a routine. You cannot do it regularly. You have to think about an interaction every time if you have an unexpected or more adverse drug effects. If you have a new drug prescribed by a new doctor who even don't know that you have CML and you take those drugs. On the other hand, if you take a drug for a very long time, you should ask your doctor or pharmacist if you stop the drug. Maybe this influence that's vanished and you have no longer this influence. And if you need over-the-counter drugs, you should discuss this with your doctor and pharmacist as well to identify interactions. And I think that's always a very individual decision, and because it depends on your response, on the amount of the drug you take. And so if you do that, you should quite safe, even if you have to take more than one drug with your TK antagonist. So I'm open for questions.
Thank you very much. Thank you very much for your nice. I think the new profession, new medical profession, the clinical pharmacologist or clinical pharmacist, become a very important profession now in the area of polypharmacy. And when, to my experience, many doctors do not know how to interact with patients that take more than 1 or 2 or 3 drugs. So I think in these cases, the patient should ask the doctor to be consulted by clinical pharmacologist or pharmacist.
Yeah, I see it the same. That's really important to have the collaboration. On the other hand, a pharmacist is sometimes really theoretical, so it's really important to see the real patient and the situation to make a decision together with a doctor or to look for that.
Please.
Yeah, I had a question. So we've learned, very nice presentation. We've learned from being here for the last day or two that there are some people in the audience who live in countries where there's very limited access to these TKIs, and in fact, there's suspicion that some of them may be on doses that are far lower than might be therapeutic. And so what I'm wondering is, are you aware of any studies, or is anybody in the audience aware of any studies to look at the effect of grapefruit juice, for instance, co-administration with grapefruit juice, to try to reliably boost plasma levels of imatinib, maybe in patients taking only 100 milligrams, to see if that's a less expensive way of treating people in parts of the world that are economically challenged?
Yeah, that's a very good question and an idea which has arisen sometimes. And I looked for in Japan, there was a study which was planned with 10 persons, and they tried to give grapefruit juice and imatinib to save costs. And they stopped the study after 4 persons because there was no difference within the area under the curve. And I think the problem is that grapefruit juice isn't standardized. And you have ingredients which are in it, but it depends on the grapefruit, where the sun, or different things. So it's not always the same amount of those ingredients which influence the enzymes. So that may be a problem, and it's not, from a pharmacist perspective, not safe to have a juice or something which is not standardized. And on the other hand, you have, no, it's not for CML, but for the breast cancer, lapatinib, you have higher levels if you take it with fat. And there were some discussions to save costs if you have patients who have only to take half or a third of the drug with fat, but you need 50 grams of fat to take it, and it's not always the same that your meal with your fat. So it's, from a pharmacist perspective, not really safe to do that. Maybe, but as long as you have no ingredients which is really standardized, and the liver is different, and you have different enzymes, so it may be an idea, and if you think about limited resources, but it's not really practical. It is not really safe.
Yes, please.
I got it.
What about paracetamol? Like, do you have any data if it does affect the TKI treatment?
As far as I know, paracetamol has no effects. But so there are a lot of drugs which are quite safe to take it with those drugs.
If I may relate to the question, maybe paracetamol has no effect on the TKI, but the TKI has a great influence upon the level of paracetamol, sometimes to a degree of intoxication. for people who take paracetamol regularly, not once in a time. So they should be very careful with paracetamol and TKIs.
So you have to look for the drugs as well, which are influenced by the TKIs as well. So you have some with those statins. They are influenced by those as well because the TKIs are inhibitors as well, and they may rise the dose of that as well. So you have to look at for both reactions.
Yeah, I got a question regarding delivery. Do you see a possibility of delivery himself oral? Because going through orally, you always have to go through the stomach. If of reversible, going back to IV intravenous delivery, of these TKIs for a certain group of patients, where it goes direct into the bloodstream, and then you don't have this complication of going through the stomach process.
But you don't have TKIs which can be taken IV. So it always depends. It's a possibility if you have the opportunity to have a drug which can be given via IV, but as for now, there's no TKI available for.
But do you see a possibility in the future where if the problem of IV, I know it's a very difficult process, if this difficult process of delivery into the bloodstream is overcome, you see, is it a better way to deliver these TKIs?
But as I don't know whether I understand your question. Do you think it's better if you take it IV?
Yes.
But there's no IV drug on the market to do it, and you can't not. It's very complicated to have an IV drug to produce that, and it's so you can't produce those drugs by IV.
Giora, please.
I want to try to ask you a practical question and things that maybe we as CML advocate can influence. As Yayo said, we find out in practical life, most doctors do not know about interaction between drug. We go and ask them and they just answer, we don't know, I need to check, and sometimes it takes time to check. Many patients don't see pharmacists. They don't receive the drug from pharmacists, so they don't get the chance to ask the question to pharmacists. And then we send them to the internet because there are some websites where you can put the name of the drugs and see the results. But there are different names for different drugs in different countries, so it's very complicated for a patient to try to get an answer. Do you think it's practical to help us develop some type of guide which we'll be able to do in different languages, which patients will be able to use and help them find a way to go through all this interaction between the different drugs?
Yes, to a certain extent, that may be possible that you have some basics or some drugs which are really very often used, and you can say you, instead of say clarithromycin or erythromycin as antibiotics, you can take azithromycin, which has no interactions. So that may be possible, but if you have really a lot of drugs and it's complicated and you have a lot of data or in the internet, but then you can see there is an interaction, but you need someone to value the interaction, to say it's really important for you. And so it's to a certain extent you can say really you have to avoid that and that drug. But to make a decision what to take and to reduce the dose or to increase the dose, that's always very individual. So it's quite difficult to really find a good solution for every patient by looking within the internet. So if I look there, you have sometimes different databases and they have different informations because it, from the producers, there are some studies and they have to value it's clinical relevant or it's not clinical relevant. Some say 10% it's okay, some say 30% is okay. But if you're on a high dose of a drug and you're very sensitive to that drug, that may be for you not very good. So you can, maybe that's an idea to have short some basics on that, but if there are problems, if you have side effects, if your drug don't work and you don't know why, I think then you have to contact pharmacists or someone, and maybe you, with web-based and so you can look for a counseling with a doctor and with a pharmacist to do that, to ask your question or give your list and say where you have to look for and what you have to do. But to do it by the patient itself, it may be to a certain extent, but otherwise it's very complex and very complicated.
I have a comment for Mr. Joris. Sorry, Mr. Chairman, Professor Bogdanovic speaking here. I have a comment on this. Yeah, that's me. I have a comment concerning the possibility to create a table. Many drugs have a different, very opposite action. So we have information that some drugs are doing action on cytochrome enzymes on 2 sides, and we are not aware which side will be in a particular patient. For the common drugs, it's very easy, especially for drugs which can be taken by the patients as pills. The rest of the drugs for IV compounds, especially drugs used in hospital settings like antibiotics, real antibiotics, anti-infection drugs, anti-epileptic drugs, those drugs should be taken by control of a doctor. So you should put the pressure on your doctor doing that. We have the same situation in Serbia, and we created to our patients some kind of a help and provided them information that some drugs which can be bought here as OTC, even they are registered for the hospital use, should be taken with a certain level of, let's say, proof that they are safe and they are not evaluated. So it's a very nice idea, and it should be it would be supported, but for the drugs which can be used by the patients at their home, not for the drugs on the lists, because all those lists are gathering information about the hospital, many hospital drugs.
Please. The subject is very, very exciting, and I'm sure there are many questions, but we are over time, and I advise that people who have questions will meet Annette at the break, and I want to thank the speakers for their very exciting presentations, and I hope we shall continue today in other sessions.